Hello, my name is Joel Topf, Kidney Boy on Twitter. I was invited to give a talk on social media in the pandemic. And as I was going through this, I really decided to drill down more on medical education, because I think it's been a pretty remarkable ride that we've been on, given the challenges to medical education. So let's take a look at this. So as I was reviewing this topic, it was amazing to me just to see the speed at which this overtook us. So a reasonable place to start the discussion would be January 9th. This is when the World Health Organization announces a mysterious coronavirus-related pneumonia in Wuhan, China. 2 days later, on January 11th, Chinese researchers released the complete viral genome. And on January 15th, the NIH and Moderna start working together to design an mRNA vaccine. I love that the name Moderna actually has mRNA right in it. January 21st, the very first patient with the Wuhan coronavirus is identified in the United States. But the real crisis begins a few days later in Lombardy, where they get a tremendously damaging outbreak in northern Italy, with ultimately going to be 100,000 cases, 17,000 deaths. Eventually, over a third of the population get infected. The first community-acquired outbreak in the United States is February 24th in Kirkland, Washington, where a cluster of influenza-negative febrile respiratory illnesses, ultimately shown to be SARS-CoV-2, were discovered. First admission was on February 24th. This outbreak ultimately results in 129 cases and 23 deaths. And then another real high-profile case is March 6th. This is the Grand Princess that was sitting in San Francisco Bay. 21 people ultimately were positive, initially it was 21 positive. Ultimately, 101 passengers were positive, and 3 of them died. Probably the most monumental date in the early pandemic is March 11th. This is when Rudy Gobert, the center for the Utah Jazz, turned positive for SARS-CoV-2. And the NBA responded by canceling, or at least suspending, the remainder of the 2020 season. And it's crazy to think about. One player became positive and they canceled the season, right? A few weeks ago, Tennessee Titans had 23 cases and they had a single game rescheduled, right? We have become so immune to this over the time. It really is remarkable, the changes. But that kind of sets the stage of this kind of early pandemic. And I would make the argument that this COVID pandemic is the most challenging medical education problem we have ever faced, right? A, it's a massive worldwide problem. B, we don't know what the truth is. Like, how can we do medical education when we don't even know what to teach? We're still trying to get a handle on what this virus represents. Third, medical positions, things that you're teaching, end up being intensely political, resulting in pushback from parties and stakeholders that we normally don't think of when we think about medical education. And lastly, this is an evolving pandemic with more and more patients getting infected every day. This is not a situation where we can take our time to evaluate and think about it. We need medical education solutions immediately. And then, those are kind of the challenges. Here are some of the resources that we would normally expect to be able to deploy to solve a medical education problem that we don't have, right? One, there are no experts, right? Try to find, in March of 2020, try to find a SARS-CoV-2 expert. They don't exist. They're being generated on the fly. 2, we can't do lectures, right? Social distancing regulations prevent us from our kind of standard way that we're going to do our teaching. And aside from that, is due to the lack of personal protective equipment, and even medical schools really pulled their medical students from the hospital. Really, a loss of bedside teaching as a resource in the way we do teaching. And then lastly, and this is kind of an aside, I said that there's no experts, but there's also a particular and individual challenge for journals, right? The whole journal infrastructure is designed around this 90-day acceptance, right? If you take a look at the average time from submission to publication, you're looking at about 90 days. And with the beginning of the pandemic in February and March, that plummeted, at least for COVID-19 manuscripts, down to about 10 days. And that sounds like a huge success. That's awesome. But what it really is a tremendous stress, right? There's not that many people that are experts in viral, respiratory infections. And the ones that are available, now you're asking them to speed up their review process dramatically. So more work for fewer people. Like, take a look at the rise in the number of manuscripts. The bar graph is the number of manuscripts per month. And by May, it's up to 6,000 plus per month, and it's continued at that rate. And the dark line is the cumulative number of publications. So as of late November, there were 60,000 manuscripts on SARS-CoV-2. It represents 6% of the total output that we've seen in terms of the academic journals, just a dramatic fraction. And what you have is a very small proportion of those people that are experts or knowledge about respiratory viral infections or epidemiology to be able to review them. You're talking to Raj Mehrotra about the challenge that they faced. C. Jason, he's the editor-in-chief at C. Jason, says, our volume surged 80%. We did more expedited reviews in 2 to 3 months than in the previous years combined. It strained our reviewers and editors considerably, and they actually added an additional editor just to deal with the press of new publications. And one of the consequences, it sounds like what I'm talking about is kind of a generic, is that really important? Oh, so the journals had to work hard, but it ended up being pretty significant. And so probably the centerpiece story of that is Surgisphere. And this guy, Sapin Desai, was a vascular surgeon, and he put together the Surgisphere, which was supposedly a company that integrated information from electronic medical records from 671 hospitals on 6 continents, all around the world. And he used that electronic health data to produce 3 documents, a document on ivermectin, and then 2 very high profile ones, one on antihypertensives, another one on hydroxychloroquine. The antihypertensive one was published and then retracted from the New England Journal of Medicine. And the one on hydroxychloroquine was published in the Lancet and then retracted. And in the end, this was all fraud. There was no EMR there, but it had, even though there was no EMR there, it had real world consequences, right? Following the publication in the Lancet, the World Health Organization halted its trial of hydroxychloroquine because of the very high safety signal that was seen in the Lancet article. This was ultimately restarted, but it caused a delay and confusion and chaos in a clinical trial. The ivermectin one is interesting. This one never made it to a peer-reviewed journal. It was just published as a preprint, but it showed absolutely amazing effect size for ivermectin protecting patients from SARS-CoV-2. The Kaplan-Meier curve on the right is just, it's off the hook. The effect size is just absolutely dramatic. And this had immediate and widespread effect, even though it was never published in a peer-reviewed journal. It was published in April 6th. By May 8th, Peru was including ivermectin as an official clinical guideline. May 12th, Bolivia also approved it for use. And then in late May, the whole Surgisphere's world completely unravels. The preprint ends up disappearing from where it was being stored. It never gets published in a peer-reviewed journal. But it took a long time for these recommendations to be unwound. It really established a standard of care, mainly in Latin America, that took literally months and really complete right through the first wave of the disease before it was reversed. Those were very high profile ones, but we saw this also in nephrology. So this was one of the first major publications that focused on nephrology. It was 26 autopsies of patients looking at kidney biopsies. And one of the images there purported to show viral particles inside the kidney. So these are electron microscopies, and it's pointing to what it says are coronavirus. But if you take a look at the publication, there's this editor's note there saying, hey, we're actually not sure that these are coronavirus. They may just be organelles. And I think a lot of people now believe that those are just clathrin-coated vesicles, and it was just a miscall on the part of the EM. And I think this is something that if you had the time, if you weren't trying to get this out in 10 days with a quick turnaround, and you had time to get the proper reviewers, this probably wouldn't have been published this way. So I love this picture. This is the very last noon conference in my hospital before we canceled this kind of lecture. And I look at it and it feels like it's from another era. I can't believe that we used to pack residents into a room like this to learn for a noon conference. And it's kind of, it's fitting that the very last lecture before we canceled them all was on the novel coronavirus. But it dramatically shows that there was a need for new solutions. What FOAMed really means is we do a massive democratization of who is giving lectures. Instead of just a few appointed experts at the front of the room, really everybody is deputized to provide their angle and their aspect of medical education. And people that find it to be appealing or useful or helpful will use it. And I think one of the perfect examples of this is in the Surgisphere story. And so, these two articles were published in the New England Journal of Medicine, The Lancet, the highest of high of medical journals. And soon after publishing, there started to be significant chatter on blogs and on social media about these articles. And so this one from this journal, this blog, Statistical Modeling, Causal Inference in Social Science, carefully looked at some doubts about hydroxychloroquine. And one of their first concerns was just, how they were controlling the data. They thought the effect size was quite large for hydroxychloroquine and probably wasn't adequately controlled for severity of illness. A follow-up article one day later said, actually, there's a little bit more problems here. It looks like the variance from country to country, like taking a variable like smoking, they were almost the same regardless of which continent they're on, which just didn't fit with what we knew about the variance from continent to continent. And somebody actually took the data from the supplements, plugged them into Google Docs, and created a spreadsheet where you can see what the variance was and how unlikely it would have been by random. And then here was a comment on the blog, which actually pointed out, and this was actually interesting. This is a comment that was really important because it ended up being reused in argument after argument as people took down these Surgisphere articles. It was pointing out that the number of deaths reported by Surgisphere in Australia was greater than the number of deaths that were reported in the entire country by the government. And then here's another comment that just was looking at whether they would have had access to the National Health Service. So they purportedly had data from England, but Great Britain uses the National Health Services, and they would have had to record whether they had access to this data, and they were unable to find any record of Surgisphere getting any access to the data. And so these were some of the initial questions of whether this data was real at all. And this type of questioning of data and points and challenges normally would have been done by letters. You would have sent a letter to the New England Journal of Medicine and the letter to the Lancet, and you can imagine how slow they would have been to responding to that, especially since it really called into question their own article. Like there's an incentive from the New England Journal of Medicine maybe not to publish that letter if it makes them look foolish. And this post-publication peer review that was open, collaborative, rapid, and viral, like lots of journalists and other influencers were able to look at this and republicize it and increase its reach. And so we ended up getting a pretty quick retraction for both of those articles. And so kind of moving on, kind of similar post-publication peer review, let's take a look at a Nephrology Journal Club. And so first I want to talk about This is a pretty benign article in the British Medical Journal, just kind of talking about preventing a COVID-19 pandemic. And there was a rapid response that was published by the British Medical Journal, and then also a correspondence in the Lancet addressing the same kind of issue. And both of them were talking about the possibility that the high case fatality rate that we had seen in China had some pretty important risk factors that people had already been reporting, mainly hypertension, cardiac, and diabetes. And the authors pointed out that all of those were indications for RAS blockade. And it's very likely that a lot of the patients that died were on ACE inhibitors or angiotensin receptor blockers for indications for their primary diseases. And they pointed out that the SARS-CoV-2 receptor is the cell surface receptor that allows the virus to enter the cells is ACE2. Now, I had not heard of ACE2, but angiotensin converting enzyme 2 is actually kind of the brakes for the renin-angiotensin system. And this was the enzyme or the cell surface marker that the virus used for cell entry. And they pointed to, both these articles pointed to animal studies showing that both lisinopril and losartan can significantly increase mRNA expression of cardiac ACE2. Now, this all of a sudden led to their theory that maybe ACE inhibitors and angiotensin receptor blockers were increasing the lethality of the disease, allowing more viral entry into cells. And it really was kind of classic selective reading of the medical literature, right? First of all, that study was looking at cardiac ACE2. And the real question was, what about ACE2 in the pneumocytes of the lung? And that had not been addressed in that article. And in other animal studies, they actually found just the opposite, that angiotensin receptor blockers and ACE inhibitors actually lowered damage to lung tissue following infections with that. Those studies were based most on SARS-CoV-1 from the original SARS epidemic. But you can imagine, how inflammatory this was, right? Lisinopril is the second most prescribed drug in America. Losartan is the 9th most prescribed drug. We're talking about, in combination, 160 million prescriptions for these two drugs per year. It was like throwing a lighted match into a room full of gasoline. It was almost immediately picked up by the lay press, talking about blood pressure medicines that could make SARS-CoV-2 more deadly. And I think a lot of doctors were pretty receptive to this idea of maybe we should be using ACE inhibitors because it's very similar to the stuff we've been talked about, SADMET, drugs to stop during acute illnesses, and ACE inhibitors and angiotensin receptor blockers are high on that list of drugs that maybe if you're getting acutely ill will be a drug to stop. And one of the important aspects of this is we talked about the problems with peer review, but these correspondence and rapid response don't go through a standard peer review. These things are going to get published pretty rare, pretty raw, without a lot of processing. And two of my friends, Swapnil Hiremath and Matt Sparks, saw this and were pretty concerned. And what they started to do, they started to review the whole chain of evidence leading to these recommendations from these authors to stop ACE inhibitors and angiotensin receptor blockers. And ultimately, they wrote a very long narrative description on the entire topic of SARS-CoV-2 in the kidney. It ended up being 32 double-spaced pages long. But they didn't do that on their own. One of the things that they did that made it possible is they assembled a team of experts in hypertension, ACE2, ACE1, scientists from around the world to assist with this project. And they did a tremendous amount of work. And it wasn't just one revision. It was daily revisions for a long period of time as they started to add additional information, essentially reviewed all the important papers that came out. Some of them just preprints, some of them actually mature articles that had gone through peer review, and putting them into place and and really doing a commentary, kind of a continuously updated narrative review of the topic. And part of it was they kept track of all the professional societies and scientific societies and their recommendations on what should you do about ACE inhibitors and angiotensin receptor blockers. And they kept track of that. I think there was ultimately 16 of them that made recommendations. And the answer was, we don't have any data, don't do anything. And this ended up being so successful that we repeated the model. So that was for hypertension and ACE2. And SARS-CoV-2. But we repeated that for the topic of acute kidney injury, dialysis and CKD, pediatrics, and transplant. And it was just an incredible success in terms of taking a look at the amount of traffic these articles generated. So we normally do about 20 to 30,000 visits a month on the NEFJC website. And in the month of March, we had over 300,000. So an order of magnitude more traffic than we normally see. And as this team became experts in what they were talking about, they started responding to articles that were being published that weren't very good. They would write letters to the editor. They then got chosen to write review articles and even some original manuscripts. So it was really very productive for them academically. So kind of in summary, NEFJC is a learning platform, learning and discussion platform. That's what we do when we have nephrology journal clubs on Twitter. But as a byproduct of that learning platform, the people that participate in NEFJC, we've developed this rich network of interested nephrologists and scientists. So that when the crisis came, they were able to quickly assemble kind of a loose federation of collaborators and quickly organize that information in the way that the community needed. It was very successful if you measure it by traffic or if you measure it by publications or even references in the literature. I'd never seen NEFJC referenced in the literature before, but we started to get a lot of references as people were pointing to that primary document. And that was kind of the unusual thing that NEFJC did during the COVID pandemic, but we also did our typical thing. So there was this article in KI, we talked about it just briefly, this autopsy series, it became a NEFJC chat. And then our podcast also became dominated by COVID discussions. So we did 5 COVID podcasts. And one of the changes that we had done previously, it had only been the hosts talking, but we started to bring in experts. This became necessary as we really needed people that had expertise in whether it was hospital administration. Keith Belovich is a chief medical officer. He was super helpful. Michael Hung is a AKI researcher. Very interesting to talk with him. Chirag Parikh was working on ways to create dialysate. If you remember, there was massive shortages in April as we were running out of dialysate, and he had a solution for that, essentially using the technology that we used for CRT, using the technology we use for your hemodialysis water purification to create CRT fluids. Agnes Fogo, a pathologist, helped us with the autopsy study, and Osama El-Shameh was a fellow in peritoneal dialysis that talked about acute PD. It was and it really changed the way that we did the podcast. We've now realized that having experts on all these podcasts is really helpful. We do that regularly now. There's another case study. This is Howard Lukes. So I got this direct message from Paul Sufka, and he's a rheumatologist, and he was very concerned with the information coming out of the CDC. He was worried that it was being contaminated by the Trump administration, something that we now know to be true, that he was really ahead of the curve on this, and he really wanted to kind of educate his government officials. He was wondering if I wanted to participate. And I said, this sounds great. And what he responded with is, I'll add you to a group of people who's working on writing this letter on behalf of multiple specialties. And the product ended up being this article right here. And it really transformed in a few days from when it got started, from a letter to politicians to just a blog post that would be promoted on Facebook. And it was pretty generic stuff. First introduce people, what is this COVID-19? It's just not the flu. It has a much higher mortality rate, especially for the elderly. Talked about what it means to be exponential growth in a doubling time. And we were seeing this happen in the United States. And then we talked about, what kind of thing, what can you do as an individual? We'll talk about flattening the curve and the importance of social isolation. And, it was signed by, half a dozen or so specialists from various different medical specialties. And it just took off like wildfire. This was Howard the following day saying we had 350,000 visits overnight. And that, he hosts his own blog, and he went from 1 to 2 servers to 8 to 10. And a few days later, he said that it was up to 1.4 million. And ultimately, there were 5 million people that saw this post on his blog, 2 million on Kevin MD that picked it up, and another 1.5 million on Medium. Just, nearly 8 million people ended up seeing this, or over 8 million people need to see this. And this was before I had seen my first case of this. It was still a week before I saw my first case of SARS-CoV-2. Excuse me. So, and to me, it really showed the power of Facebook amplification. It ended up being that was what was driving all those blog visits. Was this had been picked up by the Facebook's algorithm as something that was of interest. People were clicking on it, were sharing it a lot, and it just got massive amplification. Really, really wild to see that happen. And it was a valuable public health message at a time when these things were important. I ended up getting fielding a lot of phone calls, a lot of people that were planning different events. Should we cancel this? It's a wedding, it's a summer camp, what have you. And I was able to help them with guidance on this. And a lot of that expertise came from having been an author of this article. Next case that I want to talk about is Bob Wachter. Bob Wachter is a professor and chair of the Department of Medicine at the University of California, San Francisco. And he's 62 years old. And UCSF made a decision that people that age were going to take them off of clinical responsibilities. And you think, well, he's an administrator as chief of medicine. He'd have other roles there. But they also created an incident command task force to kind of handle this crisis of SARS-CoV-2. And so he really had nothing to do. And so he just started becoming an expert on COVID, reading all he could, and then just started tweeting about it. And then a few days later, he said, well, we're doing our grand rounds on Zoom because of social distancing. There's nothing that will stop us from making it a public Zoom. And so he turned the grand rounds into kind of a public medical education, and they were very successful. Their very first one had 58,000 views, and they were able to sustain that. Not quite 58,000, but a steady 30,000 people every week tuning in to see UCSF's grand rounds. They were always on COVID. He got various experts in, really created a very successful public education, certainly geared at high level for physicians, but taking a look at the best information that we had on SARS-CoV-2 and distributing it. And to me, I love this story because it's right. What you have is you've got an expert in medicine, and he gets sidelined. The virus really sidelined him. He was bored. He didn't have anything to do, and so he turns this into becoming a Twitter and YouTube star. His Twitter count was pretty significant to begin with at 20,000, but just massively ballooned in a few months to 150,000 since he really became one of the experts that you could count on for reliable information about the COVID pandemic, and really went from no video presence at all to 30,000 viewers a week. The curbsiders are a phenomena with or without the pandemic, but it's interesting how the pandemic changed them also, right? They covered all different topics in internal medicine. But as SARS-CoV-2 overtook the whole kind of world, the whole kind of landscape, everything else kind of faded away, and all their podcasts, not all their podcasts, but a lion's share of them really became dedicated to talking about the virus, whether they're doing journal clubs on the most interesting information or other talks about ARDS and intubation and other types of skills like that. This is an important part about that. And they were able to reprogram their normal narrative to talk about this because this is what people needed to learn. And, that's kind of on the highest scale, curbsiders get 60,000 listens every week, but it's happened on a microscopic level too. So Nick Mark is a pulmonary critical care doctor. And he has, your pulmonary critical care blog, and he's talking about vitamin C and tactile fremitus and kind of things that a critical care and pulmonologist would talk about. But what he saw, his audience changed with the development of the SARS-CoV-2 pandemic. And he saw that people started, lots of people needed to become kind of critical care doctors in a hurry, right? We were trying to staff up these ICUs, and there was a real need for teaching here. And he realized that he had this opportunity to do this. So he kind of changed his orientation and started creating these one-page cheat sheets to keep people to teach people, what are the modes of the ventilators? How do you wean somebody? How do you recognize and treat acute respiratory distress syndrome? How do you troubleshoot high peak pressures on the vent? These are all super useful things, and he brought it down to a single page. That was his brand, one-page cheat sheet. Just a real good way to readapt for all of a sudden a new population that had low knowledge and needed to become ICU doctors on the fly. So Nick Mark was a blogger. He saw that his audience changed, and so he changed the content to match what this new audience really needed. Perry Wilson. So Perry Wilson is a nephrologist and a clinical trialist, and he has a recurring gig on Medscape called Impact Factor, where he writes an article and then does a video every week or so on a different topic, usually in medicine, sometimes in nephrology, but not always. And so like every other person who was in this space, he was paying attention to COVID-19. And on March 20th, the International Journal of Antimicrobial Agents published the first trial of hydroxychloroquine. And the following day, Donald Trump said this was really a panacea, big game, one of the biggest game changers in the history of medicine is what Dr. Trump had to say. So on the 25th, Perry said, let's take a look at this. Let's go through the evidence on hydroxychloroquine. And the evidence ended up being pretty weak. This was a trial of hydroxychloroquine versus controls. They were looking at PCR positive samples as their outcome, 16 controls and 20 patients with hydroxychloroquine. This was not randomized. Controls were really patients that didn't get the drug for whatever reason, including patient refusal or doctor not prescribing it, so a convenience sample rather than a randomized sample. And there were a number of people that were excluded from getting from the hydroxychloroquine. Even though they got hydroxychloroquine, they were excluded from the final study. And a lot of them were because they were transferred to the ICU or died, which doesn't seem like a very good reason to exclude them from the study. And so, this was his kind of final conclusion. He said he's a Bayesian, the way he approaches these studies. He said he was 50-50 on hydroxychloroquine before, and after reading the study, he was still 50-50 on it. He said not only because it was just observational, but there was differential loss. It just didn't add anything to him. The study wasn't helpful in moving the needle. And so that was kind of his lukewarm response. He wasn't trashing hydroxychloroquine. He kept the possibility that it would work, but he just was saying that this study doesn't help. And there were a number of people on YouTube that watched this video that were very angry, and they were people of a particular type. And they took it out on the video. They reported him to YouTube. They flagged his video. They said that this video was too positive for hydroxychloroquine. It was promoting an unproved therapy, which is something that YouTube already said, hey, we're going to block people that promote these unproven therapies. And so YouTube came and they pulled the video. They absolutely pulled it from the site. And more importantly to Perry is they gave him a strike. And so YouTube watches carefully to people that get videos reported and then removed from the site. Because if you get 3 strikes, they will eliminate your platform. This would have been really damaging to Dr. Wilson's kind of his platform. And so when he got that strike and the video removed, he posted about the experience on Twitter and got a lot of support from some pro-science YouTubers who were able to lobby to get the video put back up. So he was very lucky. And the strike ended up being removed. But he was chastened. He was concerned that this type of these politically active people or politically minded people were able to suppress his video. Now, he eventually got it back on, but he worried about what about other people that weren't as well connected? Would they have been able to get the same outcome? And so kind of when you kind of look at his story, Perry had his particular audience, typically physicians that he talked to, but when the virus came, his audience got a lot more broad. And he saw a change in his comments. People started accusing him of being a radical lefty, being a part of the deep state, or just a Democrat. And so it was an interesting change. And, I talked to a lot of people, a lot of public physicians, and I always ask them, what are you doing about politics? And most of them try to intentionally ignore it. But Walker had this interesting statement. He says, if you're really covering and digging in on COVID, invariably, you're going to result in a discussion of policy. And that is political by its nature. He just really doesn't think it's possible to do this by being apolitical. And this is kind of the last case that I want to talk about, Preti Milani. And Preti was a co-student of mine in medical school. We went to medical school together. And she had an interesting career, and she ultimately became the chief health officer at the University of Michigan. And as a role as a chief health officer, she really did an occasional interview, about the football team. If there was somebody who was injured, she would get to talk about it on the radio, what have you. But when the virus came, all of a sudden, she blew up, right? She went from an occasional interview to 400 TV and radio interviews between February and September. It was absolutely mammoth, the exposure that she got. She ended up being the face of a number of important decisions that governed how the school would open. People found her Facebook account and had one-way discussions. And so what you had is Preti talking through, broadcast media and through social media to a large audience. But what she didn't expect and is kind of new is those same people were able to talk back to her either through Facebook or other social media accounts. And some of them were pretty hostile. People use the distance that is provided by social media to be rude and sometimes threatening. And this is something that she didn't really sign up for and wasn't expecting, and ultimately had to disable her Facebook account just to preserve her mental health. And this is something that's been repeated kind of over and over again. Amy Acton was the director of the Ohio Department of Health. She was very high profile. She was right there in the front row in early March with the Governor DeWine declaring a state of emergency. They started daily press briefings on March 12th. Closed K through 12 schools very, very early. And on March 22nd, one of the first stay-at-home orders. And Ohio really was ahead of the pandemic and was doing extremely well because of this very aggressive positioning that Amy established. But, some people didn't like it. And these are protests that were happening outside her house, right, in her neighborhood. And this is just, again, not something that she signed up for. And on August 4th, she ended up resigning. There was a nice article in JAMA that talked about these attacks on public health officials and really, what it means. These people are really just dedicated public servants, and they're getting attacked in ways that were largely unfair. In this article, they mentioned that 70% of local public health officials reported receiving threats. And this is just one of them, Emily Brown of Rio Grande County. She ended up being fired on May 22nd for making unpopular but probably scientifically sound decisions keep the people safe. And so, we one of the great things about social media is how close it puts people together, but that closeness can backfire in situations where you're making opinions that may be unpopular. So that's kind of a trip through the use of foam med in our kind of the first medical education crisis in the age of foam med. And there was a lot of different solutions. And I think that was what I found so exciting, is that there wasn't one right answer of how to teach and how to solve the med ed crisis in a pandemic. There were dozens of right answers. And whether it was spontaneous YouTube stars like Robert Wachter, or using blogs and comments to do post-publication peer review, or Twitter chats to disseminate new information and new techniques for dealing with shortages of dialysate. Podcasts, still a really powerful force that's rolling on. Creating cheat sheets on the fly for a new audience of people that need to be facile in ICU medicine, and the generation of informal teams like the FJC scientific collaborations to do review and kind of a continuously updated review article on COVID-19 and the kidney. It was pretty impressive. And I think that type of diversity of solutions is really what is remarkable about free open access medical education. Thank you.